Well, greetings, everyone. My name is Dimitri Prybylski, and it's my pleasure to give a virtual presentation. A couple of notes. I've got a little bit of sinusitis and postnasal drip, so if I cough a little bit like that, it's just a minor thing. I'm in totally good health, just so you know. Two is the slides I'll be presenting are a bit text heavy, and that's done intentionally so that those who don't get a chance to see this video are able to follow along just from the materials, the written materials. And then also a third note that there'll be plenty of resources, links to websites, published reports, and published manuscripts that I will be sending on to the conference organizers, so you'll have that available. So my strong congratulations to you all on joining this workshop, and I'll be speaking to you. I've been invited to speak on how we can apply what we've learned from combating HIV stigma, discrimination, and misinformation in responding to the COVID-19 pandemic. And there are two major things I'll be covering. One is really an overview of the HIV pandemic and the connection between epidemiologic and socio-behavioral factors or issues, and then also how we apply the lessons from the global HIV response to COVID-19 response, particularly as it relates to stigma and discrimination. So first, a bit of an overview of the HIV pandemic. So as of 2019, there are 38 million adults and children living with HIV. And they are 1.7 million adults and children newly infected with HIV, and 690,000 adult and children child deaths due to AIDS. So despite a lot of the progress that's been made in reducing HIV incidence over nearly 3 decades, there's still a heavy burden of disease globally, particularly in Eastern and Southern Africa, where really you'll see the burden of disease mostly focused, but with global reach. So this next slide shows the estimated global HIV incidence over nearly 3 decades, going back to 1990. And you'll see that the number of new infections basically maxed out at around back in 1996, 1997, and then has been steady declining, not overly deep slope, but it is declining. And the dot over here is the UNAIDS 2020 benchmark goal of 500,000 new infections. So we're quite a ways from that at 1.3 million. Okay, on to age-related deaths over nearly 3 decades. Here you'll see the max really was later on, as there's a delay between the time of infection and death in 2000, early 2000s. And there's been a decline in deaths all the way down to in 2010, and there are about 690,000 deaths globally now, which is fairly close to the benchmark of 500,000. But what's also interesting is that age-related deaths by sex, you'll see real gender difference there, differences emerging there too, as mostly related to the fact that women are disproportionately going on to antiretroviral therapy at a greater rate than men are, and therefore also you're having a decrease in age-related deaths as a result of that. There are other factors at play as well, but that's thought to be the main one. It's important to know that ART is not only a form of treatment, but it's also a form of prevention as well, because those who are adhering to therapy on ART are also at minimal risk of transmitting it as well. And this the whole paradigm of treatment as prevention. Now, this next slide is actually quite important. The first part of it really shows the distribution of new HIV infections by population. And it's important to note that that new infections are really concentrated in key populations. key populations are populations that are at disproportionately high risk for HIV infection, and that includes sex workers, people who inject drugs, gay men and other men who have sex with men, transgender people, and also the clients of sex workers and sex partners of the key populations. And there's a lot of regional variation in this distribution, but it really has a focus on the most vulnerable populations. And that's true of most diseases and pandemics. And we'll be talking about that as that relates to COVID-19 as well. Now, you can also see the gender distribution as well. And it is interesting to note that females 15 to 24 years of age are represent 20% of infections, whereas males in the same age group are only 12%. So young women are at disproportionate risk too. And there's a lot of issues to do with gender equity, the lack of empowerment of young women, the epidemic that the response has really been fighting to through various initiatives, but there's still work to be done to tackle these entrenched inequities. So key populations and HIV/AIDS. So as I just displayed, people who belong to key populations are more vulnerable to HIV infection. And the reasons are complex and they relate to numerous factors, and these are some of them. One is related to the transmission of the virus itself. The mode of transmission is really through bodily fluid, blood, semen, rectal fluid, vaginal fluid, breast milk, and our main modes of transmission. And as a result, high-risk behaviors such as injecting drugs or unprotected sex, which allows for the exchange of these body fluids, are really going to lead to transmission. And unfortunately, these behaviors are also stigmatized and marginalized by society, and key populations are often fearful or ashamed to access health and HIV-specific services as a result. So why is there stigma around HIV/AIDS? The fear about the HIV epidemic really emerged at the onset, and this is often the most scary period, is when little is known about how the virus was transmitted. This fear was exacerbated because, at the time, HIV had, basically was a universal health sentence before death sentence before treatment was widely available, and HIV. There was also a long lag. There's a long lag between the time of onset of initial symptoms and actual death, and that was very scary because as well, and led to a lot of anxiety as people didn't know whether they were infected or not before HIV tests were widely available. And so HIV is associated with behaviors that many people disapprove of in society. Globally, issues around homosexuality, drug use, sex work, or infidelity, there's a lot of stigma associated with those behaviors. HIV infection is seen as a result of often being seen as being personally irresponsible or failing morally, and this led to victim blaming and otherness, which is a real distinct human attribute of us versus them, which we see going back to when diseases were first being documented, that there's often this lack of inclusion that really needs to be addressed. And also inaccurate information about how HIV is transmitted created misperceptions about personal risk as well. And on that front, misinformed beliefs were often and are still exaggerated fears of HIV infection, the concern that it could be casually transmitted just by being in the same room with someone or touching something that the other person may have touched. So that is sort of, I think, largely decreased over time, particularly in high prevalence settings. And there's data and publications that support that over the decades, that there has been a reduction in stigma and discrimination. But it still very much persists globally, and I'll show a little bit more about that. Major disinformation themes include that HIV is not being the cause of AIDS. There was a lot of AIDS denialism by state governments and unfortunately by university professors and academia who had a lot of influence with state actors, and this had major repercussions because if you don't have a government that's supporting public health programs, that's and what scientists are saying, that's often always a problem. HIV, another one was that HIV was created and disseminated intentionally as a form of genocide, and this is also another major source of disinformation. The belief that pharmaceutical companies or a government were basically had intentionally done this as a form of genocide, and then also that antiretroviral therapies are harmful and that a cure is available, but it's secretly being withheld. So it's also important to know that like some of these conspiracy theories or sources of disinformation, it's important that they often are better framed as inequity-driven mistrust, that they're not considered irrational things, because if you're a member of a subpopulation that is marginalized and is encountering on a daily basis systemic racism or marginalization, stigma in terms of accessing services or just in general daily living, well, it's really easy to understand how there can be these beliefs that are then incorporated and the susceptibility to that. So the early stage of the HIV pandemic predated the widespread use of the internet and social media-driven infodemics, and that's probably a fortunate thing, because we know from COVID-19 and from more recent infodemics just how social media can really drive and amplify mis and disinformation. Not to say that HIV, that infodemics don't occur related to HIV. I just don't think at this point they're as profound. All right, so now I'm going to talk a little bit about an overview of progress towards UNAIDS' zero discrimination target. And this slide really shows discriminatory attitudes across different regions, and you'll see different countries for each of those different regions. And they cover different timeframes for each of the countries, but they're all between like 2000 and 2019. And you'll see that there has been a steady decline in the population, adults who would not buy vegetables from a shopkeeper living with HIV, which is in this case an indicator of stigma. And and so that's been a really a good thing to see. But at the same time, there are other countries and other geographical areas where it's still a major issue, even something as basic misperception as this. All right, this next slide looks at the percentage of people living with HIV who experience different forms of discrimination in healthcare settings. And you'll see there are four kinds of discrimination in healthcare settings. One is the ability to obtain ART conditional on the use of certain forms of contraception. And then that a healthcare professional has ever told other people about the HIV status without their consent. And also that they're forced to submit to a medical or health procedure, including HIV testing, because of their HIV status in the past 12 months. And finally, they were denied health services because their HIV status was at least once in the last 12 months, they were denied health services. So you'll see that these are unfortunately not that uncommon in many settings. It's something that still exists and is a challenge even 30 years after the pandemic really started. So this schematic really shows how stigma leads to sickness. So many of the people most vulnerable to HIV face stigma, prejudice, and discrimination in their daily lives. And issues like HIV, sex work, sexuality, drug use, and gender all tie in, are all stigmatized in different ways in different settings around the world. And they lead to issues around poor health service access and uptake, harassment and abuse, discrimination and violence, which all leads to marginalization as well, that then has deleterious effects on emotional well-being, poverty, and also leads to um, risky situations and behaviors as well. And this all in the end leads to morbidity and mortality. And so it's just, I think, an interesting diagram to sort of show the confluence of risk behaviors in sort of a more epidemiologic sense and some of these wider societal socio-behavioral issues and how they play in. So this also shows the percentage of people aged 50 to 49 who reported discriminatory attitudes towards people living with HIV. Again, showing that there's widespread discrimination around the world too. Sorry, I'm just trying to figure out why this isn't working. Oh, I see. It jumped. I'm sorry about that. All right, so this slide shows common forms of HIV stigma and discrimination, and just showing that it comes in various forms: self-stigma, internalized stigma, governmental stigma, restrictions on entry, travel, and stay that have a lot of parallels, I think, to COVID-19 as well, healthcare stigma, employment stigma, and community and household level stigma as well. So lessons from the HIV pandemic that can inform our global response is really the next section. And this is a quote from Michelle Sidibe, the former executive director of UNAIDS, who I think had a really eloquent quote that whenever AIDS has won, stigma, distrust, discrimination, and apathy was on its side. And every time AIDS has been defeated, it has been because of trust, openness, dialogue between individuals and communities, family support, and the human perseverance to find new paths and solutions. So this slide really, I think, is a good slide for sort of showing some of the various dimensions of how we can respond to stigma. One is really focusing on human rights for all, the policy and legal framework by which you can protect populations, and inclusiveness of the actually key populations themselves in healthcare service design and implementation, and in interventions to reduce stigma and discrimination as a goal in national strategies. Also, empowerment to understand rights and to act on violations, and also education to address fears and to change attitudes and to really get the right information at the right time for action as well. So I wanted to touch a little bit on some lessons learned from HIV social media strategies and interventions. There are a couple of systematic reviews that have been conducted recently, and I'm going to give you the the citations here too, and I'll give you more resources as well. But the first one really looked at social media and HIV, and it was a systematic review of uses of social media in HIV communication. And the most common benefits that the studies reported were, access to HIV information was enhanced. There was an enhanced ability to communicate. There was having an anonymous identity really was incredibly useful to break through situations where they would have had to be physically present. It would have been much more of a challenge. A sense of social and emotional support, and really establishing virtual communities, safe virtual communities where people could have social contact and not be concerned about being arrested or something bad happening to them. There are some disadvantages that the studies reported as well, that related to technology barriers for certain populations, cost, the lack of physical interaction, and ironically, the lack of privacy and concerns where the whether there was a social app that was asking for personal information, etc. So, I think it's definitely been promising. I think the kinds of studies that have been done, the kind of indicators, the sort of methodologies that have been are in no way standardized, and I think there'll be some really more interesting reports coming out as well. But in general, there's definitely we've seen some really useful ways that social media can enhance getting information out to counter misinformation and disinformation. And then the next review was really looking at interventions to promote HIV testing, and then other linkages to care and treatment as well. And the main findings were really that social media was being really used among gay men and men who have sex with men and transgender populations. And this is these key populations were using social media interventions to a much larger degree than others. And this may be due to the early adoption and popularity of social and sexual networking sites among these populations as well, again, as a way to get around the stigma and discrimination, which would be present, unfortunately, if they were to do that in a more physical setting, like a bar or a nightclub or something. So, and then importantly, linkage, when you looked at HIV testing uptake, this is also higher as a result of media, particularly when it was the participatory and peer-driven methods were being used. Okay, now I want to sort of touch on a couple of reports that have come out recently. The first one by GPC and UNAIDS looked at lessons learned from HIV prevention, preventing COVID-19 in low and middle income countries. And there were lessons from HIV prevention that could be applied to COVID-19 in low and middle income countries. And some of the things were like building strong community-led responses early on. We are all in this together. Basically meaning that in HIV and AIDS prevention, the realization that if you don't work locally with communities and they don't own the responses and they don't own the intervention design and are not being linked in a broad way to societal and structural interventions, it doesn't work as well. And so it's so critical to do that. Also, multi-sectoral coalitions moving beyond health. And we saw this with the creation of UNAIDS, which was really coordinating various UN bodies beyond health to address the sort of broader societal challenges that HIV and AIDS present. And in many ways, is much broader than a health issue. It really cuts across all aspects of society. And so that's something that's being looked at as well as a lesson learned that could be applied to COVID-19. As related to key and vulnerable populations, really prioritizing them and not leaving them behind, and using a human-centered, rights-based approach to do that. I've been working on HIV for 25 years now, and I have to say it's really incredible to think about when I first started my career and just how difficult it was to have work with and understand the importance of key populations and get beyond the stigma and discrimination, and to see how widely now programs that are working with these populations and are tailored and integrated for them it's really a great thing to see. And hopefully we won't have to go through all the pain of years and years wasted to get there when we with COVID-19. Also, action-oriented communication to stimulate behavior change. Messaging matters for prevention. So really, how do we develop communication strategies that are most likely going to stimulate behavior change? So obviously for HIV, things related to safer sex practices and safer injecting drug use patterns were really critical. For COVID-19, they may be more related to social distancing, face mask wearing, washing hands, etc. But there are techniques and strategies in terms of developing interventions to really get communication to foster this behavior change. Also, innovation in the time of physical distancing. As I actually, some of the slides I just showed about social media and HIV really apply here too, where so many of us are in lockdown around the world, or having to work out of our homes, and not socially interact the way we'd normally in a physical sense. How we use social technology, social media apps, mobile technology, is really going to be critical in terms of coming up with innovative prevention. And I know that's a major theme of this workshop. Also, taking action to scale rapidly. We've learned a lot programmatically about how to do that with HIV, as well as tracking peer accountability, tracking and peer accountability as well, in terms of developing solid logical frameworks and monitoring and evaluation platforms and scorecards to monitor progress. Okay, another report that UNH put out recently, really writes in the time of COVID-19, had similar lessons learned too, but some of them are different. First of all, obviously, at the forefront, engaging affected communities from the beginning in all matters of the response. You'll see those are at the top of the list for both of the reports. Additionally, addressing all forms of stigma and discrimination, including those based on race, social contacts, profession, healthcare workers who are celebrated in many settings in COVID-19, but also have been the victims of stigma and discrimination in many settings, both in terms of the HIV response and also even early on with COVID-19. And then also with marginalized populations as well, those who are socioeconomically already being marginalized as well, or the victims of racism or other forms of stigma. And we see the disproportionate burden of COVID-19 already in many of these populations, even early on. Ensuring access to free or affordable screening, testing, and care for the most vulnerable and hard to reach. A lot of aspects of universal health care, so that those who often can't afford health insurance are able to access services and not be denied because they can't pay for them out of pocket, has been incredibly important. In countries that built in have really reaped the benefits. Removing barriers to people protecting their own health and that of their communities, including fake news and misinformation. That's another major recommendation. Restrictions to protect public health need to be balanced by societal adverse consequences, especially to vulnerable populations. So really saying that we have to be really careful the way restrictions on movement, on a range of things, that they're done in an equitable way, and that certain subpopulations who are vulnerable aren't basically suffering from them, and not able to sort of lead their daily life because of them, and striking that balance. Countries must work to share information, knowledge, resources, and technical expertise. This is also something that we've learned over time on the HIV response, that having sort of in a community of a practice, so that, and research, where the lessons learned of and best practices from countries can be shared and adapted without having to start start from the onset, and basically be able to do it in a more efficient way as a result, has been a really something that's been incredibly useful in the HIV world, that could be applied to COVID-19. So finally, I wanted to just have a final slide about issues for addressing stigma for really any pandemic. I think any new pandemic, to me, it just seems these are really cross-cutting. So number one, new diseases like COVID-19 are really scary, and particularly when there are still so many unknowns. I think this is a particularly vulnerable period, and there are lots of challenges associated with that, as we learned from HIV. And we are often afraid of the unknown and associate that fear with others. And this is what unfortunately often leads to quite dramatic stigma and discrimination early on. and it continues, but it's just this particular early vulnerable period. And there's also a vicious cycle between stigma and disease, where people who experience stigma and discrimination are marginalized and made more vulnerable to disease. And then also people living with the disease are more vulnerable to experiencing stigma and discrimination. And this is unfortunately a cycle that is iterative and leads to extreme challenges. Also, misinformation and disinformation increase stigma and discrimination, but can be addressed in tailored information environments, both digital and non-digitally. We talk a lot about infodemics, about social media. It's important to realize that many of these populations aren't necessarily connected, vulnerable populations, to social media, and they're tried and true methods of community engagement, working with faith-based leaders, community leaders, using celebrities, politicians who are popular opinion leaders to really drive acceptance of important public health behavior change and to help respond to misinformation and disinformation. Also, adopting community-driven, human rights-based approaches are keys to mitigating stigma and discrimination. And we saw that earlier, just how important it is that the communities themselves are in the driver's seat in terms of that. So with that, I'd like to thank everyone for listening in, and I will definitely make available links and resources to all the materials that I presented on. And also, giving my email address, and if you have any questions or follow-up, feel free to email me, and I would be happy to correspond with you. And I'm sure that the conference organizers can help with that coordination too. So thanks again. Best of luck as the first cohort of infodemic managers, and I look forward to seeing you in person, and not only in a virtual way as well. Thank you very much.